when hematologists are facing with an older patient with hematological malignancies, first we have to think about the option to cure our patients, because some hematological malignancies can be cured if we select the appropriate therapy to all of our patients. But older adults are not going to be candidates to receive high doses of chemotherapy, and sometimes we do not offer them a curative approach. So the aim of geriatric hematology is to identify which patients are robust enough or fit enough to be treated frontline with a standard therapy like younger patients in order to cure them. In order to identify which patients can benefit more for the therapy, we should perform a comprehensive geriatric assessment. But before that, we can use a screening tool like the G8. G8 stands for Geriatric 8 Questions, and it's a screening frailty tool that we can explore in patients with some kinds of hematologic malignancies, such as acute leukemias and also aggressive lymphomas. And we can identify which patients are in risk of frailty, and those identified with this screening tool can be referred to a geriatrician for a multidimensional approach in order to get the comprehensive geriatric assessment, in order to be classified into 3 different phenotypes, like robust patients or fit patients, intermediate or vulnerable patients, or unfit or palliation patients. One of the challenges is that we do not have a geriatrician in all of our institutions. So hematologists must address how to classify patients with the resources that they have in their own institutions. So the use of a screening frailty tool like the G8 is going to help us in order to identify only which patients may benefit from a further or comprehensive assessment. And those patients that are identified as frail, we should be trained, if we do not have a geriatrician in our institution, at least to assess the more broad assessment in our patients. And for example, for older patients with lymphoma, we know already that the assessment of comorbidities and also functional assessment with ADL or IADL is of relevance to be assessed in order to decide which therapy is going to be more appropriate to them. Yeah, in the field of aggressive non-Hodgkin lymphoma, we have data coming from different studies. And for example, for patients older than 80, now we know that they need less chemotherapy than the one that we give to our younger patients. And for example, for patients 80 plus, instead of giving the standard therapy like R-CHOP, we can give a reduced dose, which is R-mini-CHOP. And with this dose reduction, we are not going to have a worse outcome. The outcome was going to be almost the same as younger patients, but with less toxicity. From my point of view, the best take-home message that we have to take from this SIOG meeting is that we must not undertreat fit patients, because they can benefit from a standard therapy like younger patients, because the aim is to cure them, and not to overtreat unfit patients, because we are not going to improve the survival and we are going to give only toxicity. So with these 2 main messages, we have to learn how to identify these 2 different subgroups of patients in order to give the best and tailored therapy to them.